Hello, I am Randall Oyer, a co-principal investigator for the Optimal Care Coordination Model Initiative. On behalf of my colleagues, I will be presenting our poster titled An Optimal Care Coordination Model for Medicaid Patients with Lung Cancer, Finalization of the Model and Implications for Clinical Practice in the U.S. Advances in cancer therapies have not benefited all populations equally, with a higher burden of disease often experienced by socioeconomically disadvantaged groups and other vulnerable patients. In particular, Medicaid patients require enhanced cancer care services to achieve equitable outcomes with non-Medicaid patients. The Association of Community Cancer Centers, or ACCC, launched a 3-year initiative in 2016 to develop, test, and refine optimal care coordination model to help cancer programs identify and reduce the barriers experienced by Medicaid patients by strengthening care delivery systems for lung cancer. The initiative included 3 phases. As part of the first phase, an environmental scan was conducted, which identified 6 broad barriers to optimal care delivery for Medicaid patients diagnosed with lung cancer. The barriers were financial and social, unequal access to high-quality lung cancer care, limited patient engagement, inadequate integration of patient navigation into multidisciplinary cancer care teams, underdeveloped multidisciplinary team approach to care coordination, and limited emphasis on funding for, access to, and utilization of supportive services. In the third phase, the beta model was deployed at 7 community-based cancer programs, which implemented quality improvement projects over a 12-month period. This is described in a companion e-poster labeled Abstract 105. The final model was refined based on the results and experience of beta testing at the 7 testing sites. Revisions were implemented to enhance clarity of intent and ensure ease of use and reproducibility, specificity, and uniformity across the assessment areas. The technical expert panel, advisory committee, ACCC staff, and consultants further refined the model as part of a 2-stage process and used a consensus decision-making approach. The final model comprises 12 interrelated assessment areas, with each having at least one evidence-based measurable parameter for continuous monitoring of quality improvement. The levels of care coordination for each assessment area are rated from 1, which is indicative of fragmented care, to 5, which is indicative of optimal care coordination with a patient-centered focus. Progress to a higher level of care coordination implies cumulative and sustained fulfillment of lower-level criteria. The final model can be deployed at any cancer program, regardless of size, setting, or resource level, to help identify disparities, strengthen and expand access to optimal care, and articulate aspirational goals. These efforts may extend beyond lung cancer to other tumor types. The final model is being disseminated nationwide by ACCC through its extensive network of U.S. Cancer Program members. More information can be found via the QR code. To conclude, refinements to the model were informed by the experiences and results of beta testing at 7 cancer programs. The model can be used by cancer programs to conduct objective self-assessments of their capabilities across 12 high-impact areas of care delivery for lung cancer to prioritize the unique care and treatment needs of Medicaid patients as an important step toward ensuring equitable health outcomes with non-Medicaid patients. Nationwide dissemination of the model across a wider network of U.S. cancer programs has high potential to advance multidisciplinary coordinated care delivery, define value-based care delivery metrics, and improve clinical outcomes for other vulnerable patients, regardless of cancer type. On behalf of my colleagues, we would like to thank the Advisory Committee, Technical Expert Panel, and Lead Clinical Research Consultant for their valuable contributions to this initiative, and to Bristol Myers Squibb Foundation for funding support. We are also grateful to the patients and participating staff at the development and testing sites under this initiative. Thank you for listening.